Hello. Hello, everyone. Just gonna give folks about a minute or two to get settled, get comfortable, log in. Hello, everyone. We'll get started shortly. Thank you for your patience. About 30 more seconds. The final countdown. All righty, folks. Good morning, good evening, good afternoon, depending on when and where you're tuning in to this webinar. On behalf of the Association of Asian Pacific Community Health Organizations, I would like to thank and welcome you to our webinar today on building a quality improvement prevention program for Asian American, Native Hawaiian, and Pacific Islander patients with prediabetes. This is going to be a really great introductory webinar, giving you a quick overview as well as health center perspectives. And we're going to close out with a really awesome Q&A section. So let's get started. So before we go into all of the content of the webinar, I want to share some Zoom logistics, especially to those who are not familiar with Zoom or maybe the webinar function. So first, this is a highly participatory webinar. So we encourage you to either comment or unmute yourself to speak. However, since this is a really large webinar, we ask that you raise your hand first and one of our moderators can unmute on behalf of you. And then the next function is our Q&A. So if you have any specific questions for the panelists, please submit your questions in the Q&A box. The Q&A box, you can also like comments and respond to them, so it's very interactive. And our panelists really welcomes questions, so we really highly encourage you to use this function. The next function is the chat function, just for general comments and to share anything that you would like. And in this function, you can also speak with specific people. So if you have any technical issues or anything, you can also ping one of our moderators via this function. And then on the lower right-hand side, you can also leave the meeting. But once you leave the meeting, we also ask that you fill out a short survey for us so we can continue to improve our training and technical assistance content. So thank you ahead of time for filling out this survey. And then the moderators today is first myself, Sakura Miyazaki. I am the program manager of training and technical assistance. And I'm with two of my colleagues here today, Jen, who is our deputy director, and she will be doing the Q&A section. And then our Asen Jr., our Associate Director of Training and Technical Assistance. He will mostly be in the background today, but he's doing a lot of the behind the scenes work. So if you have any technical issues, please feel free to directly chat him in the chat box. And we are all a part of the Association of Asian Pacific Community Health Organizations, or AAPCHO for short. And AAPCHO is a nonprofit association that is dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders. So AAs, NHs, and PIs for short, which we're going to be using throughout the slides, within the United States, its territories, and the freely associated states. So AAPCHO is currently comprised of 32 member organizations majority of them being health centers across different states, territories, and freely associated states. And our amazing panelist today, it works at one of our member organizations, JD Caradia-Bordo. She is the Director of Health Promotion and Disease Prevention at Waimanalo Health Center in Waimanalo, Hawaii. She formerly worked as an epidemiologist in the TB branch for the Department of Health in Hawaii. And she is a graduate from University of Hawaii and has an MPH from Oregon Health and Science University. So thank you so much, JD, for joining us, and I cannot wait to hear what you will be sharing today. So Albert, if you could launch the poll, and I have it on the screen if anyone else can't see it on their end, we would like to get a feel of who we're talking with today. So please, if for about 30 seconds, we would like for you to identify which best describes your organization type: a community health center, a primary care association, a national training and technical assistance partner, health center controlled network, government, academic institution, or community-based organization, or other. I'm gonna give it about 20 more seconds, so please select which best describes your organization type. Right, about 5 more seconds. Great. So the majority of us are community health centers with some government, academic institution, and community-based organizations. I love the diversity in the room, so I'm looking forward to all the great questions that we can hear from you guys. So next. So why are we all here today? We have 3 main learning objectives for this webinar. First is to increase knowledge regarding the health challenges and disparities for Asian American, Native Hawaiian, and Pacific Islander populations with respect to diabetes and prediabetes. And with this, we want to share culturally and linguistically responsive quality improvement strategies that influence health behaviors in these communities, once again related to diabetes prevention. And then we want to wrap it up by fostering discussion regarding these strategies and resources that target these patients with prediabetes. So reflecting on our learning objective, our agenda, we're going to start out with a really quick overview of Asian American, Native Hawaiian, and Pacific Islander populations and their health disparities. And then JD is going to provide the amazing health center perspective from Waimanalo Health Center. And then once again, we're going to wrap it up with the Q&A. So before we get into the nitty-gritty of diabetes and health disparities in this population, we really want to go over who we are talking about today. So who are Asian Americans, Native Hawaiians, and Pacific Islanders? And the definition on the right is the official definition from HRSA of Asian Americans, Native Hawaiians, and Pacific Islanders. And the map on the left kind of gives you a visual of the countries of origin and ancestries of these groups. And as you can see, there is a variety of continents, countries, and time zones. So in short, Asian Americans, Native Hawaiians, and Pacific Islanders come from a variety of geographic regions. More than 50 ethnic communities and 100 languages are spoken in this one group. And then looking in the United States and its territories, there are 23 million Asian Americans, Native Hawaiians, and Pacific Islanders. And that has grown from 2010 to 2019 by 60%, so an increase of about 9 million folks. And then this is projected to grow to 39.4 million by 2050. And then when we look specifically at health center data, we see that in 2018, health centers served just a little under 1 million Asian American, Native Hawaiian, and Pacific Islander patients. In 2019, that number grew to 1.3 million. So once again, the population is growing, and then these patients served at the health centers that are Asian American, Native Hawaiian, and Pacific Islanders are also growing. And this is data from 2019, so we anticipate data from 2020 to be showing another growth. And then the map at the bottom shows the health center locations throughout different regions in the world. Once again, to summarize, Asian Americans come from a variety of geographic locations and live and are served in a variety of geographic locations, and the population is increasing as well. So just lots of diversity. And then when we want to talk about diseases and disparities, before we dive into diabetes, I do want to contextualize it in the sense of it's not just diabetes that Asian Americans, Native Hawaiians, and Pacific Islanders experience health disparities. And this is very evident in infectious diseases. So when we look at tuberculosis or hepatitis B, we see that especially compared to non-Hispanic and white populations, Asian Americans and Native Hawaiians and Pacific Islanders have a higher rate of tuberculosis and hepatitis B. And AAPCHO also has other training and technical assistance material to discuss these infectious disease disparities, so definitely check it out. And then now we're going to dive into diabetes. So when we look at diabetes, a lot of the common narrative can show that Asians have one of the lowest rates of diabetes. So this graph is from the Center for Disease Control and Prevention. And as you can see, compared to white and non-Hispanic populations, Asians maybe have 0.5 or 1% higher rate of diabetes, not as significant as other racial or ethnic groups. And blanket wise, it might be that that's the case until we look at the disaggregated data. So when we disaggregate Asian American, Native Hawaiian, and Pacific Islander data, it's just much more illuminating information. So first, when we look at Native Hawaiian and Pacific Islander rates of diabetes compared to white populations, it's much higher. So we see that Native Hawaiian and Pacific Islanders have 15.2% of diabetes compared to white populations. And when you break that down into Samoans or other Pacific Islanders, we see that these rates are even higher. So Native Hawaiians and Pacific Islanders, who are often aggregated under Asians, actually have higher rates of diabetes than white populations. And then we can look at specific health center data. So this graph on the left is from our report from last year that looked at health center data. And when we disaggregate the data, once again, by Asian American, Native Hawaiian, and Pacific Islander patients, we see that Native Hawaiian and Pacific Islander patients do have higher rates of diabetes than white populations, correlating to disaggregated data. But then Asian Americans have the lowest rates of diabetes. So once again, can we take this as blanket statement? What's really going on here? We're gonna disaggregate once again from the Asian American data. So when we look at Asian American subgroups, we see that specific subgroups such as Filipinos and Indians have higher rates of diabetes than other subgroups, even more than the white population. So once again, when we disaggregate the data more and more, we see the complexities of disparities of the diseases in Asian Americans, Native Hawaiians, and Pacific Islanders. So why do these disparities exist? There is a ton of great research that is discussing this exact issue. And one of the first things is incomplete screening standards. So typically the American Diabetes Association, the ADA, identified that patients with body mass index or BMI greater than 25 are considered at risk for diabetes and should be screened. However, when they look at the Asian American population, the ADA acknowledges that they need to be screened at a lower BMI of 23 instead of 25. And then we can look at social determinants of health. So social determinants of health are the conditions in which people are born, grow, live, work, and age. So healthcare qualities, external context, economic stability, education access and quality, community context. These are all things that impact diabetes prevalence in a community. And then we can also dive deeper into SDOH by looking at immigration and non-communicable disease. So Asian Americans account for about 5.6% of the US populations. Native Hawaiians and Pacific Islanders account for 0.5% of the US population, but they account for a significant portion of 37% of immigrant arrivals in 2018, and that number is estimated to be growing once again. So this higher proportion of social risk factors in the communities influence diabetes prevalence. So looking at things like language barriers, discriminations, cultural norms, food intake, all these things that are impacted by immigration and healthcare providers can influence diabetes prevalence. So wrapping up with this information, looking at prediabetes, when we look at the prevalence of prediabetes in these communities, we see that Asian Americans, Native Hawaiians, and Pacific Islanders once again have one of the highest rates of prediabetes compared to white populations, and the highest among all other racial and ethnic categories. So being underscreened, and then this happens. So quick poll. Albert, can you launch the poll, please? So 2 questions to summarize what we learned today. What contributes to prediabetes and diabetes disparities for Asian Americans, Native Hawaiians, and Pacific Islander populations? Incomplete screening standards, high proportion of social risk factors, lack of culturally and/or linguistically appropriate care, and all the above. The next one is a fill in the blank. Asian Americans should be screened for diabetes at a lower body mass index of 23, 24, 25, or 26. I'm gonna give it about 15 more seconds.
And we have about 50% voting right now, Sakura, so let me know when you're ready to close.
Great. Give it about 5 more seconds. Looking real good. All right, let's see. The answer for what contributes to prediabetes and diabetes disparities for these populations, all the above, great job. Fill in the blank. Asian Americans should be screened for diabetes at a BMI of 23. Great, thank you so much, everybody. Okay. So the large key takeaways after all that data was thrown at you. And no worries, this is recorded and you can access the slides later. But Asian Americans, Native Hawaiians, and Pacific Islander populations are extremely diverse in their countries of origins or ancestries and where they're located and living in the United States, and they're growing in raw number. And then when you aggregate Asian Americans, Native Hawaiians, and Pacific Islander populations into one group, often seen as Asian, it can mask diabetes disparities compared to other racial and ethnic groups. And then when you disaggregate the data, you really see that diabetes disparities exist between and within Asian Americans, Native Hawaiians, and Pacific Islander subgroups. So now I'm going to pass it to JD so she can talk about value-based culturally appropriate programs at Waimanalo Health Center.
Okay. Hi, everyone. Thank you so much, Sakura. My name is JD. I am the Director of Health Promotion and Disease Preventions at Waimanalo Health Center here in Hawaii. And I'm just going to be talking a little bit about the programs that we offer, specifically our prediabetes programs and how we have culturally tailored them to be more appropriate for our population here in the community. And please feel free to ask any questions throughout the presentation via the Q&A, and Albert and Jen and the other panelists will help me keep track of that. Okay. So you can go to the next slide. So just in general for our agenda today, I'm going to give a brief history about Waimanalo Health Center for those of you who do not know about our community health center, the services we provide, just brief statistics on diabetes, and then focus a little bit more on our programs, and also touch briefly on our quality improvement aspect of it using Azara. Okay, so Waimanalo Health Center was opened back in 1992, and we are a federally qualified health center. We're a patient-centered healthcare home, so we focus kind of on the patient, what are their needs, and we integrate a lot of our services here. Our mission statement, or our statement, is Ola Ikawai a Ka'opua, which means that there is life in the water from the clouds. And this is basically sharing that, you know, water brings life, and water creates life and sustains life. Part of our values is Malama, which is to care for each other, or just to care. Ohana, which means family oriented, community oriented, and pono, which is what is right. So we try to embody all of these values in our health center, and when we give our services from outreach all the way to medical services. And this is a picture of our health center, by the way. Okay, so including some of our services. So we do primary care here. And we also offer dental services, which has been expanding. We offer vision services. So if people come here or our patients come here and they need multiple services, we can easily refer them out to either dental, vision, or our behavioral health services. We recently added a pharmacy, actually. So patients can choose to get their medications here, but we also send it out to other pharmacies. It's just easier access for patients. If they're already here, they're more likely to pick up the medications when they're at their appointments. We do a lot of support services. So that includes my department, which is health promotion. We do a lot of programs, outreach with the homeless, and we also work with the Kiki, which is the children in the community, and we do a lot of child programs, which are Kukia, our other outreach program does, and they also work across with the elementary school. And we also have Maiola services, which is our cultural services, and we have a cultural practitioner and her program, which focuses on Lomi Lomi, which is massage, and La'au Lapa'au, which is Hawaiian herbal medicine. And they have been integrated with our primary care as well, so providers can refer to them. You can go to the next slide. Okay, so just briefly, a little bit of diabetes statistics. So like Sakura had mentioned, that diabetes is increasing throughout America, and 2 in 5 Americans are expected to develop diabetes in their lifetime. Specifically in Hawaii, this might not apply to all of you, but in Hawaii, the Native Hawaiian and Pacific Islander population is 3.32 times more likely to die from diabetes than the overall Hawaii population, which includes a big variety of Asian Americans and Pacific Islanders and Caucasian Americans. In general, why do we want to focus on prevention and educational programs? And that is because in Hawaii and in our population, Native Hawaiians are actually more likely to seek educational services about diabetes and prediabetes compared to our overall population. So it is very important to make sure that we give them access to this type of education, and not just give them access to it, but try to give them access to it in a cultural way, and really focus on the importance of Hawaiian culture and how people are associated with that. And another reason is that Native Hawaiian and Pacific Islanders are more likely to develop complications compared to the overall Hawaii population from diabetes. So they're more likely to develop like kidney problems, and more likely to have amputations as a result of diabetes. You can go to the next slide. So one of the programs that we offer here, we call it our Malama Pono'i program, and that is, we are CDC recognized for the diabetes prevention program. So if any of you have heard of that program, it is a year-long program that focuses on diabetes prevention and lifestyle changes. And it's 1 hour for every week, once a week, for about 6 months, and then once a month for about 6 months. So it's between 22 sessions to 26 sessions. And we focus on 150 minutes of exercise per week. And we facilitate group discussion. So it's a group-based discussion on how we can track our lifestyle changes so that we can live a life where we don't develop diabetes, or we can prevent diabetes from developing. But this was a very Western-based education, and Waimanalo Health Center has been very successful. We are CDC recognized with this program. However, a lot of the participants do show interest in having it more culturally tailored, or how do we do that? So how do we tailor our programs to be more appropriate for our population? And this shouldn't be specific to Native Hawaiians, Pacific Islanders, but just any culture in general. How do we make sure that as a health center that provides education, how can we make sure that we're understanding the needs of our population? So we at the health center, we're actually just recently started our program last week from Malama Ponui, and we are doing a value-based tailored program where we focus, we're integrating the Pili Ohana program with our Malama Ponui program. And Pili Ohana program was a program that was done by JAPSOM, which is the medical school here. And they focused more on the Hawaiian values like ohana, getting support, and the education material was based more on Hawaiian culture and using that as a means to educate people about diabetes and lifestyle changes and recruiting your ohana to help you change your lifestyle. So we've integrated that. Another aspect is speakers, like incorporating guest speakers. For example, I would, as our cultural practitioner here, which is La'au, they would focus on herbal medicine. So we have a garden. They talk about native Hawaiian plants and the importance of, growing a garden or recognizing your plants or using plants for medicine. And this is all, of course, with the recommendation of we encourage the participants to talk to their providers about this as well. Other guest speakers we have is Lomi Lomi practitioners, which is massage therapy. And so they come in and they talk a little bit about massage. And we also include our vision providers to come in and talk, our dental providers to come in and talk. And I also am trying to incorporate field trips into the course as well, because people tend to be very hands-on, and getting into the community is very helpful in people in retention in the programs, especially during your month-long program, your month-long breaks between the programs. I think I had a question.
Hi, JD, it's Jen. So the question was whether or not in the DPP, if you all have made a transition to offering it virtually in lieu of COVID, I presume.
Yes, of course. So that's an excellent question. I know a lot of us are struggling right now with how to gather multiple people in one unit, depending on which state you are, what your regulations are. In Hawaii, we have a tier system, which means we can't gather in more than 5 people, which has been very difficult, especially since people like to gather in person. And when working with our kupuna or our elderly population, they have a really difficult time with Zoom or any kind of virtual meetings. So how have we tailored it here is we adhere to the state recommendations and guidelines. So no more than 5 people, including the facilitator, can gather in person. So we do allow in person for those who do not have access to Zoom or do not have access to Wi-Fi or internet, because we don't want to exclude them just because of that lack of access. So as long as we're doing state regulations and listening to the recommendations and following the rules, then we allow in person. And we have a conference room similar to the one as you see in the picture. That's one of our cohorts. This was before COVID though. But there we have a big facility where we can accommodate people in person. And additionally, we do at the same time are doing a Zoom. So a facility like this would have the 5 people or up to the 5 people can come in person. And then we also offer through Zoom the rest of the people. So they would be on like the TV screen and you can see each other and they can participate too. And the guest speakers are on Zoom or they can come in person. So we do a hybrid program where we offer in person and we offer on Zoom, and it's synchronous. So it's not pre-recorded, or we could look into that in the future, but right now I find it more beneficial to do it synchronous so that it's active communication and live communication with our participants. Thank you for that question. Okay. So that is the diabetes prevention program here, and we offer this program 1 cohort to 2 cohorts a year, depending on the need. So you can go to, I'll go a little bit more into our other programs as well. I'm sorry, I think I got another question, and I love answering questions throughout the program, throughout the presentation. So
sure. The question was, are health plans covering the DPP program, and if so, how are patients, if they have to, do they have to pay for the program?
Okay, excellent question. So we do not charge for the program here at Waimanalo Health Center. It is an enabling service here. So there is no payment that is required from our participants. As long as they're a patient of the health center, they are not required to participate in any of our enabling or pay for any of our enabling services. We currently do not bill for Medicare. So we are not billing for this service. This is free to members of our health center. However, we are working with, so this current cohort, we are working with Hawaii Primary Care Association, which is HPCA, on this specific cohort to maybe see in the future if we can get Malama Ponui or the diabetes prevention program covered by like Medicaid or other insurances. So this is kind of like a pilot of that and seeing how that would go, so that in the future we can offer this as treatments and bill for it. I hope that answers your question. We are doing.
I think the other question was just if Jillian was asking if you'd be comfortable sharing your email contact.
Yes, of course. I would be more than comfortable sharing any of my email contact and information. Okay. I think that was all. So we can go to the next slide. Okay, so our Ho'opono and Hanapu program is our diabetes self-management program. So we do the diabetes prevention program for those who want to participate in that and that lifestyle change. Similarly, we do a diabetes self-management program. A lot of individuals, and I'm sure many of us have similar experiences, when they hear pre-diabetes, they don't get as concerned. And then they get to a stage that maybe they develop diabetes and didn't take the proper steps to prevent it. And so now they are new to diabetes. And that's what this program is. It's not just it's for people who have been maybe dealing with diabetes for a long time to kind of help those that are newly diagnosed with diabetes. So this program is a 14-week program and is recognized by the AADE. And it's 2 hours a week instead. And so this one is facilitated by a certified diabetes educator, whether it's our RD or a psychologist. Right now we use our psychologist to facilitate. So this we do bill for under the diabetes educators. So under a CDE license, this program can be billed for. It focuses similarly like the diabetes prevention program. It focuses on tailoring the program. So we have the psychologist talk, and then I also bring in other guest speakers after that focus a little bit more on diabetes. We also offer incentive programs. So people who participate, they can get gift cards, or right now we're developing an incentive store so they can get rewards for meeting certain goals, such as a scale, kitchen supplies, something that promotes a lifestyle change. It's always great to use incentives as goal-oriented because it increases the likelihood of participants getting involved and actually meeting those goals. So for example, we would have, this is a previous cohort a few years ago, but we had the Hawaii Bicycle League come, and then we were able to do like kind of a Hawaii bicycle tour with the participants that wanted to participate in that. So that Ho'opono is the group program, and this is also similar. We've made it into a hybrid program for in-person, and we have people can repeat multiple times for this program. We never like turn people away if they want to participate multiple times, because they have the knowledge and they can give feedback on how we can improve the program. And they also can help those that were newly diagnosed after participating in the program. So I try to change out the guest speakers because of that reason if people are participating multiple times. Our Hanapu program, though, that is individually tailored because not everyone excels in a group environment. So the Hanapu is one-on-one with the RD in the clinic, and she does diabetes education with them and also bills under the CDE for the Hanapu. Okay. So currently I had a question that asking in regards to the pharmacy. So currently our pharmacist is not involved with our DSME program in the, like in the sense that there's not a direct, they're not like teaching the class or anything, but I do bring them in as guest speakers. So for like the topic where we discuss medication, I try to get our pharmacist to come in and talk a little bit more to the participants about their medications. If they have any questions, it's a great opportunity for participants to ask the pharmacist. So they're not directly involved in the program management, but they do come in as a guest speaker because we do promote that. Okay. So we can go to the next slide. Okay, so diabetes isn't the only thing that Asian Americans or Pacific Islanders struggle with. Hypertension is a really big factor. And one of the programs that we run that has been really successful in here and only goes to show the importance of culturally tailored programs is Oloho Ika. So we ran this program back in 2019 and we ran it prior to that as well. And we are going to do one this year. But it's called Oloho Ika Hula, and it focuses on hula as a means to help control hypertension. This has been one of our successful programs in not only participation, but retention, which is always a really hard thing to achieve, especially with longer programs, year-long programs, 6-month programs. So this study came out of JABSOM as well. And it focuses on hula as a means of physical activity. So this program meets 2 times a week for 12 weeks. And then for the maintenance phase, usually 1 time a week for the additional 3 months. So 6 months total. We focus on blood pressure monitoring in this. So self-monitoring at home, especially so that people are more familiar with their numbers and they're aware of how not only physical activity can help control their numbers, but also how taking medications is directed. So it is associated with an education piece. So 1 hour is dedicated to hula, and then 6 of the weeks is dedicated to 30 minutes of education. And this is also education that focuses on hypertension, focuses on lifestyle changes. And so this program was already culturally based. And so we didn't have to tailor this program. We just implemented this program. And it has been one of our more successful programs in overall. And as far as billing goes for this type of program, this is also an enabling service program. However, certain insurances like United Healthcare do have exemptions for like if the participant is participating and they're United Healthcare, the health center has a possibility of billing for them or getting reimbursed for teaching Oloho Ika Hula. I don't know where we are as a health center in the steps of actually billing for that aspect, but it is also in the works of, maybe getting other health other insurances to follow along with allowing culturally tailored programs to be covered under insurances. Okie dokie. And then we can go to the next slide. Okay, so other programs that we offer here that maybe that we also do is our self-monitoring blood pressure program. I'm just going to briefly talk about these programs because they're not really culturally tailored. They're just programs we offer. Self-monitoring blood pressure, we do a rental program here where we rent out blood pressure cuffs to participants, and they can email it to us or they can bring it back to us. We encourage people with hypertension to be active participants in their health. And so we don't want a lack of accessibility to a blood pressure cuffs that can run $70. So we provide it for them, and they do a rental program here for a year-long program for $5. They monitor their blood pressure at home. And then we are also adopting that to be ambulatory too, for helping with diagnosing of hypertension. Yes, they are. So they are the Omron Series 7 monitors. We use Omron here, and we use the Bluetooth one. So Series 7 or higher that has Bluetooth capabilities, because for individuals that have the ability to email it in and transfer it to their smartphone device, it makes it a lot easier. It takes away that need for them to actually write down the blood pressure numbers, and it actually works really well for those people who get popularly educated with emailing it to me directly so that I can add it to the EHR. So that's the SMBP program and our ambulatory program. We also do a farmers market here right now. We haven't been doing it because of COVID, but we try to get culturally appropriate food access to people. And so I'm trying to get that back in motion. But prior to, we did have a farmers market. We offered different Hawaiian foods, just access to fresh produce in the area. And we also gave incentives for people who saw the RD to use vouchers at our farmers market. So we're in the works of trying to expand that, hopefully. And we offer Cooking and Shopping Matters. This is a tailored program for WIC participants, focusing on getting kids and mothers and fathers more involved in the kitchen. And then we have our La'au Lapa'au programs, and this is our cultural programs put on by our Ma'iola services and our cultural practitioner here, and they focus on 7 laws of health from a Hawaiian perspective, a Hawaiian herbal medicine, and that program is also really popular here because of the cultural aspect of it, and people really enjoy participating in it multiple times, and the retention is very high for that program. Did I have another question?
JD, this is a question from Raquel, back to the self-monitoring blood pressure program. So when patients send you all their results, is that a standardized message that is automatically generated via the device, or is it free text, and does it qualify to connect to UDS?
Okay, those are all great questions. So it is not a standardized message. It's an Omron Connect app. And so what happens is it exports a CSV file, and the patients just email it to me directly saying that this is my blood pressure log. And when they email it to me, I send it to the provider. I upload it in the EHR. I ask the provider what kind of feedback they want me to tell the patient, continue to monitor, adjust medications, so forth. Is this UDS qualifying? I wish. So the UDS qualifications is that it has to be like directly in real time. And because this is not in real time and it's not in a format that can be adjusted, like it's in an Excel format, which you can change, it doesn't qualify as UDS. I don't know if I can't fully speak to that, but I don't know if they're trying to change that. Okay. Okay, I think that was it for that question. Okay, you can go on to the next slide. Okay, so lastly, what I want to touch on, because this is a quality improvement, how do we integrate Azara into our programs, and what is the use of using a base like Azara? So for recruitment purposes, for all our programs, we use social media platform, provider referral websites, and we do email blasts through our patient portal. And we do Azara reports, and Azara is our online system. So our EHR goes into Azara, and I can work with the quality department and I can ask them to pull reports, or I can do it myself after they teach me how to do it. And this allows me to pull specifically participants who may be pre-diabetic or had a recent A1C that was close to 5.7 to 6.4. They are what financial bracket they're in, like Medicare, Medicaid coverage, what kind of insurance coverage they have. So it's really useful in identifying a specific group of people, whether it be for prediabetes, diabetes, food insecurity. And then and I would use that to recruit people. So I'll send them emails, I'll call them directly, or I'll have some people in my department help me call them so that we can reach out with them more directly and figure out who actually would be more likely to participate or who qualifies for these programs, because you do have to have diagnoses for these programs, so if they qualify or not. So it really helps tailor our recruitment and makes it a lot more efficient when needed. We also do feedback and evaluations from participants. So I always encourage feedback and evaluations, especially when I'm trying to tailor a program. For example, the Ho'oponopono program, we were doing the same guest speakers every cohort. And then with people who were repetitive takers of the program, they were recommended trying different guest speakers or, switching it up. So I tried that more quickly, and I keep like the most interesting ones, and then I switch out, maybe 5 that they want to see someone else, and then bring them back the next cohort. So feedback and evaluations from participants are great ways to tailor your program, especially if you have a committee that talks, that kind of evaluates the program. It's great to have a patient representative or participant representative of that program to also give feedback to that committee. Okay, and then we can go to the last slide. Okay, this was just a really quick so that you can see what Azara might look like, but an Azara dashboard kind of looks like this, where you can modify it to kind of represent your population. You can export the data. And so I could ask our quality person here to kind of develop a dashboard for me, or develop a registry, or develop measurements for me, so that I can do a quick view of what I need, or maybe how our population looks, or after we did the program, how has our data changed, or how has people's A1Cs changed in our patient population. So that's just kind of how the Azara dashboard looks. It's always very useful to have a quality department or work with a quality department in using an electronic data. Okay, and then I think there's just one last slide. Okay, were there any questions?
Yeah, I'll get us started or keep us going. Thanks so much, everyone, for chatting them in and using the Q&A box. I think this may refer to the lifestyle change program, the DPP, over time, but maybe if you could say more, JD, about measuring the outcomes of participants in that program over the course of the year, what to track and how.
Okay, yeah, of course. So the programs and how we do a pre-evaluation. So for example, for our Ho'oponopono program, we pull participants' weight, BMI, A1C, and we have them set goals as well, like behavioral goals, lifestyle goals. We ask them readiness to change. And then at the end of the program, we do it again. We see if they felt like they met their change goals. And we also look if they went to see a provider, we pull their A1C at the end of the 3 months or the end of the 14 weeks to see, has their LDLs, their HDLs, their A1C, weight, BMI, has any of that changed while they participated in the program. So we measure both before the program and after the program for multiple programs. For our hypertension program, we evaluate the blood pressure. So we look specifically just at the blood pressure and the weight for that one. For the diabetes, we're tracking their weight throughout. For the pre-diabetes, we're tracking their weight throughout the entirety of the program. So some of the programs are just in the pre and post, and some of the programs are, if we're specifically focusing on something, then it's throughout the duration of the program. I hope that answers the question.
And we had one other question that came in too. I think this is getting back to just how you all covered the cost of just operating the lifestyle change program. You mentioned that Medicaid reimbursement is still kind of underway, and the PCA is working on that in California. But yeah, how were you guys able to get that lifestyle change program going?
Okay, yes, of course. So our department and the health center is grant-based. So we did a lot of grant applications to sustain the programs. And then we also budgeted for sustainability of the program as well. And so majority of how we sustain the programs, we start the programs, is we do grant-based, we do grants. And so we have a development team that if I saw a grant that I specifically wanted to do, or if they see a grant that they think would apply to my programs, then they'll forward me the grant and be like, this might be a good one for you to apply. Or I might come to them with a program that I want to implement, and I say, do you know if there's any funding for this opportunity? And they would send me grants, or they would help me apply for grants for the programs, whether it's state, whether it's private, whether it's federal. That's how we mostly support the programs here at the health center.
Great, thanks so much, JD. Yeah, and we're gonna kind of continue the Q&A session. So please feel free to, you can raise your hand or chat us in the box, or use the Q&A box. Either method works for us. And we'll kind of take any questions that come in. Let's see. Yeah, were there any details in terms of what types of grants or funding were helpful for the lifestyle change program that might be helpful for others to look into?
Okay, yeah, there are multiple grants. So for example, we used HPCA for and this might just be applicable to Hawaii locations, unfortunately, but we used HPCA as our main grant to actually start the diabetes program. And they also pair with CDC. So it was like an HPCA CDC 1815 grant. And so we did that for the lifestyle change program. The Ho'oponopono program, that one's sustained by the CDE. So if you have, if you as a health center want to get a CDE, or if you have staff that are already certified with the CDE, then you can bill for diabetes self-management programs. And so that's how that program is sustained. As far as the HULA program that we do, American Heart Association is a really good one. They do a lot of innovative grants. What else? A lot of the medical schools too. So we got one of our grants to sustain the program through the ULU network, which is through our medical school down here for JAPSOM. And then the Cooking Matters and Shopping Matters programs, which focuses specifically on food and cooking and shopping healthy, especially for low-income families. That was actually through one of the local, Chamber of Commerce here in Hawaii. But then we also applied for the No Child Hungry one And we also do a lot of city grants, like GIA grants.
Great. Those are really helpful pro tips. I just chatted into, I think for folks who want to dive in deeper into the National Diabetes Prevention Program, just linked to CDC's kind of core information page, which has got a lot of information on the coverage efforts that are in place, and they obviously vary state to state, but we can also, I think, have done a couple of webinars on the National DPP, so we can uplift those for folks as well. So another question from Susan, JD, is just a little bit more about the Waimanalo population. How large is the population you serve there?
Okay, oh my goodness, I actually don't know this off the top of my head. I'm so sorry. I think we serve about, I believe it's like a couple thousand. So I think we're in the 4,000 range, if I'm right, or 3,000 to 4,000 range, if I'm right. Do not quote me on that because I'm honestly not sure. Our quality person might know, Nadine. I don't know if you know that specifically, but as far as our patient population, we do serve a lot of Native Hawaiians, a lot of Asian Americans. That's both Japanese, Chinese. We have a few Spanish or Hispanic populations that we serve, Caucasian Americans, and a lot of Micronesian population and Filipino population. That is also a group that we serve here. So really diverse, a lot of minority populations here at the health center.
Yes, thank you, Nadine. Yes, Waimanalo is a federally qualified health center. I had a question. I think, you mentioned just a lot of the data benchmarks you collect through the lifestyle change program. And we know that there are a lot of challenges with numeracy and health literacy. So are there some techniques or things that you all have done to help ease the burden of collecting that data, or tips you may have for others who are doing interventions with community, but also navigating the data collection piece, or adapting that process?
Yes. So for the data collection piece, we do have a standard survey that we use for each program. Sometimes it's provided by the people who did the studies. Like, for example, for the HULA program, the JABSOM provided us with a survey, and we just tailored that survey. And I get the best advice I could probably offer for tailoring and data collecting is that it's a little harder now with COVID, honestly. So I do recommend doing polls like in your Zoom. That's how I did mine for the people that participated in Zoom. I did polls in Zoom, and then you can extract it through an Excel document actually in Zoom. Under the management program, under the management tab in Zoom. So I do recommend doing that if you're doing a hybrid class, kind of like how we do here at the health center, or doing it all through Zoom, because sometimes it can be difficult to make sure it's secure, or to have people fill out the copies via email and email it back to you. So Zoom is just a good platform to use if you're willing to extract the data and create the polls. How do we tailor our evaluations or our data collection is, so in the beginning, we would make what we needed to collect, because we have to report to the CDC or we have to report to AADE. Whatever is required in reporting, we always collect that data. So I would start there. Whatever data you want to measure, if you have a quality department, maybe work with them. Or if you are reporting to a higher organization for certification or recognition, start with what they want you to collect, and then tailor a survey or a data report for that. And then as you continue your program, you can decide or get feedback from the participants on what else. Like maybe you want to do readiness to change, or you want to assess if they have behavior change. And those are always really good to talk with if you have behavioral health people in your department or in your facility. And we also have committees, like, for example, our Hopopono our committee or our diabetes self-management program, we have a committee that, I update them after the program's completion annually on, this was what we did. This is how we modified the program. And was it successful? Was it not successful? And how can we maybe modify it again so that it is more successful? Or should we sustain our incentive program because it was very successful? And having a committee of colleagues and also a participant representative, I think really helps with not only tailoring programs, but also with the data collection part, because you can see, like, really, do we need this assessment? Like, is this a necessary assessment? Maybe this isn't necessary. Like, are we even really using this data? Do we need to be collecting it?
Mm-hmm.
And so those are, that's actually one of the most useful ways I could suggest, is doing a committee with your colleagues and with participants in the program.
Great suggestion. Yeah, we have a few more questions that have been coming in. One was just regarding the outcomes of the program. Roughly, what's the percentage of patients who actually come to all the sessions? It's a long program, and the percentage who actually show those results at the year end.
That's a great question. I don't have those offhand, but I can speak to some of the programs that I've run myself here while I've been here. So it really depends on the program. I'm going to be honest. The cultural programs have a lot higher retention. So our Oloho Ikahula program, just to give you an idea, I probably recruited maybe an interest of 40 participants. And in the first week or so, all 40 of them came, between 30 to 40 of them came. But as like the commitment continued, because it's like a 3-month to 6-month program, they slow down. And so at the end of the program, I had maybe consistently in every class between 12 to 15 people. And then at the and then that would come and go. We didn't limit how many times they could come or how many times they needed to come. But by the end of the program, it was probably ended with 12 participants that had consistently completed majority of the classes. For our diabetes prevention program, though, that one's a lot harder for retention. It's actually the hardest program to retain participants in from when I've been here. And the reason that is because that's a year-long program. You're going to have a lot of fallout. And so during the weekly meetings, they're actually really good. Participants come, especially if you're recruiting in the right time. So like January, lifestyle change, weight loss, people want to participate. You can get a higher recruitment. And for the first 6 months, they're good because you're meeting once a week. But when you get to the month-long, the maintenance phase, you usually have a lot of fallout because people forget or they're not motivated to come anymore because they're not, there's no real incentive to come, which is why I want to try out like field trips or like community work for the participants to see if that would retain them more. So for a program like that, I could have recruited, like actually emailed out maybe 40 or so people and then actually called them, and then maybe only 12 of them register for the class and maybe only 8 of them attend. And then by the end of the program, I have 4 people that have actually gone through the entirety of the program because it's a year-long program. So that one is a lot harder to maintain. For the Ho'oponopono program, usually I don't actually have a lot of follow-up with that because it's a 14-week program. It's short, it's 2 hours. But for our patient population, sometimes people are really interested and then sometimes they're not interested. So it really depends on the timing of the program and the recruitment of the program. So I could have recruit between 8 or so participants, 4 to 8 participants, and then usually a majority of them will stay the whole time throughout the program, depending on how much I recruited. So for example, I had maybe this past cohort that I just had during the holiday season, we had 6 participants, 5 to 6 participants. By the end of the program, all of them participated in majority of the classes.
Are you all using just different incentives at some of those key benchmark times for the year-long program that have
For the
felt-
year-long program? So right now I actually am trying to create an incentive store because we have a lot of incentives here that we just accumulated. And so I'm creating an incentive store. But for example, like this time I decided to provide them with scales, you know, because it's a lifestyle change. They want to measure their weight at home, especially for the people at Zoom, and incentivize them. You know, this is a free rental. If you meet your weight loss goals, the scale is yours. Like at the end of it, if you meet your weight loss goals and you retain yourself throughout the program, then the scale is free of charge. You don't have to give it back. That is for you to promote your lifestyle change. There's other things that we do, like depending on what the lesson is. If it's an exercise, then we provide them with like stretch bands. And if they meet weight loss goals, then we raffle off like a Fitbit or a bigger incentive. Like everyone who completed the program and also completed their weight loss goals has an opportunity to win a Fitbit at the end of the program.
I mean, creative with all that. I know, always curious what people
Yes, it's constantly changing.
So our last question that's come in is, are the health center physicians at Waimanalo able to claim quality improvement credit for a lot of the work you're doing in prevention?
I do not know the answer to that. I am so sorry. Our quality improvement person might know the answer to that, but I do not, unfortunately, know if they do. We do UDS measures. We meet all our UDS measures because we're federally qualified. We do have meetings in regards to that, and so I don't know how it though collaborates into if the providers can claim it.
We'll see if Nadine has an answer.
Oh, good. Thank you. I'm in.
No pressure. That's a good question, though. Maybe just on Azara, on the population health management tool. Last question is, have you found that effective, kind of working with the actual coaches of the program? Do you share that data with them, just as a means for them to kind of see and stay motivated in teaching the classes and continuing, you know, over the long haul?
Yes. So we have a really small department here at the health center. So it's really just like me teaching it and maybe the RD if I can have, she has time to help me teach it. And so I do get to see like the results, which is very motivating on like just as a facilitator of the program. And I do find something like Azara or Azara itself very helpful in recruitment, and specifically for me in recruitment, and then seeing success of programs, or even seeing just overall the diabetes change or the hypertension change, especially when you're trying to meet goals like for the health center as a total, like Million Hearts or Target BP. So those are really great. It's a really great tool, especially if you have a quality department. Like for me, if I need any kind of assistance, Nadine is very helpful, or our quality department is very helpful with tailoring reports for me.
Got it. Yeah, and thanks, Margaret, for your comment too. She just said that, you know, she would think that the programs would qualify for some of the PCMH QI programs, just having just completed transformation to annual reporting. I appreciate that. Okay. I'm going to do maybe a last call for any burning questions you may have for JD. Thank you so much for kind of fielding all these throughout your presentation. We really appreciate, I think, all the information you shared and kind of what these programs can look like when they're tailored to fit what our communities are more receptive to and more likely to integrate and resonate for them. So I'll do a last call here. Let's see. I think that is it. Okay. Thanks so much, everyone, for your questions. I'm gonna, and also thank you, JD.
Of course.
I really appreciate your time and Nadine's time. Appreciate you all from Waimanalo taking the time to share all this great work with everyone. I may just transition us to our resources, just some additional supports, hopefully that'll be useful for you all on the line. Our training and technical assistance resources, we have kind of an upcoming diabetes prevention learning collaborative that we'll be launching in March, talking a lot more about some best practices in screening and referral. A part of that is the Screen at 23 promotion, and we're really trying to uplift that across the health center program, particularly for those working with Asian American populations. And I did want to share too, AAPCHO has been working with the Pacific Islander Diabetes Prevention Program, very similar CDC recognized diabetes prevention program, but also catered more towards Pacific Islander communities. And we're happy to share a little bit more information about that on our website. And again, I think a lot of the adaptations that JD talked about today are kind of this secret sauce to making that program successful. It's a bit of an out-of-the-box program, so you really have to kind of make it work well for your communities and get creative. And then also just want to continue to promote the Health Center Resource Clearinghouse. That is a bastion of information, if you aren't already familiar with it, from all the different training and technical assistance partners funded through HRSA. There's a tremendous amount of information there on diabetes prevention, which is a key priority the last 2 years. And then the Social Determinants of Health Academy, which will be another opportunity to continue, I think, a learning session or learning series, hearing from others who are working in collecting social determinants of health data and looking deeply into those interventions and then how they connect to some of the health center outcomes. So you can always email us at training@apcho.org for any questions or follow up on any of the resources that we shared today. And with that, I will maybe pass it back to Sakura.
All right, thank you so much, Jen, and thank you so much, JD, and thank you so much for everyone that participated and asked really, really great questions. Once again, when you leave the session, please take our survey to ensure that we can offer high quality TTA. And thank you so much. Any questions, please email us at training@apcho.org. Thank you so much. Take care, everybody.